Good morning, everyone. Thanks the organizer for this opportunity. So my topic of presentation is LYMPHA. It's like a immediate lymphatic reconstruction after axillary or inguinal node dissection. So why it is required? As you see, the overall survival rate of the breast cancer is from increased from 48% to almost 90% to the current era. And we are seeing most of the patients, more or more patients with the debilitating lymphedema. The percentage of breast cancer related lymphedema is around 49% with the MRM, and even with the current this thing sentinel lymph node biopsy, we are able to see around 5 to 6% of patients with the lymphedema. So for upper limb lymphatics, anatomy is variable, but there are most commonly injured channel is the medial and the lateral upper arm channel, which injured during the axillary dissection, and the tricipital pathways most of the time is intact. So these are the instrument required for the LYMPHA procedure. You need a SPY-5 cam. Initially, I started doing with the blue dye, but it is not very comfortable. ICG dye is required. Microscope with if it has a ICG function, it is well and good. If it is not, still we can manage. Sutures 11-0 is sufficient. Some 12-0 rarely required, or sometimes you get a good size lymphatic. You can do with the 10-0 also. So we start with doing taking with the ICG dye, around 1 ml of ICG dye reconstituted with the vial comes with the 25 mg, and you have to reconstitute with the 10 ml saline. So around 2.5 mg of the ICG dye we inject in the west spaces, and then after 10 minutes you get something, you get the fluorescence. You can see the lymphatics there. So this is a small animation. It is the old technique of this thing, where after axillary dissection, after giving the ICG dye, we identify the cut end of the lymphatics, and after that the most important thing is the next you have to identify a vein with a good wall, so that there should not be a backflow of the blood. And the conventional technique, you just insert all these whatever the lymphatics available that are inserted inside to the vein, and a small suture is taken so that they stay there. And as the lymphatic pressure increases, that wall gets open and the lymph starts flowing through the goes to the circulation. So this is how it looks under microscope. You see that three lymphatic vessels are inserted into the vein, and the lymph is flowing. So my technique is slightly different. I start doing the targeted axillary dissection, where what we use, like in a normal lymphedema patient, we do the LVA anastomosis end to end. So after ICG, after axillary dissection, we identify the lymphatics. Like here you see the good lymphatic here, then you identify the vein, and then you do the end-to-end the lymphovenous anastomosis. So, and with the SPY-5 you have to check the patency of the anastomosis. Also the vein is important. There should be wall. You can see there is no backflow of the blood into the lymphatic. If there is a backflow of the blood, the patency will be hampered. Another video. The case of MRM is done. There was no separate axillary incision. So through that incision, identified the lymphatic, and done end-to-end anastomosis. If there is a size discrepancy, you can do the end-to-side anastomosis also. The most important thing here, the dye should flow spontaneously across the anastomosis to the vein. You can see here, yeah, that is the vein there, and that is you can see the dye is going in the vein spontaneously. As there is no other method to monitor the patency of this anastomosis, so on table perfection is very important, because the initial only will get the results if you compare with the other axillary dissection. there will be a less drain output. That is only the, you can say that the your lympha, this thing is working. So you required at least two anastomosis. Here in this case, one more lymphatic you can see on the just beside the retractor. And the vein commonly used the lateral thoracic pedicle, that vein from the lateral thoracic pedicle. Sometimes you have to be there during the axillary dissection, so that you get the good vein and a good undamaged vein there. And if that is not available, you can take the vein from the thoracodorsal, this thing, thoracodorsal pedicle. One vein you can remove from the thoracodorsal pedicle. So there comes the question of the oncological safety. There are enough studies to show that the immediate lymphatic reconstruction doesn't lead increase the metastasis or local recurrence. So it is a completely safe procedure because it is done, even the axillary nodes are involved, it is done after the axillary dissection, and where the lymphatic from the arm is going directly into the blood. There are some modification. Some people started doing a distally based lympha, D-lympha it is called. It is more commonly done with after the inguinal node dissection, because the lymphatics in the lower limb are of good size. So just identify the lymphatic and do the lymphovenous anastomosis. For upper limb, it is a quite the lymphatics, the normal lymphatics of very small size. So you really require a super micro technique to do that. And plus, for Indian population, it is very difficult to explain patient the extra scar on the arm. So it is normally done for the inguinal this thing. So to conclude, the identification lymphatics is better with the ICG in our experience, and the preservation of good venous tributary is the key, and will require some larger studies and longer follow-ups to prove the efficacy of the procedure. Till now I have 138 cases with 18 months of follow-up, and out of that 138 cases, 5 patients developed transient lymphedema. 4 patients we managed with the conservative treatment, and 1 patient actually developed lymphedema which required a LVA anastomosis later on. Thank you.